The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety. This is the Flight Bridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today I am joined here at AMTC 2022 with Kevin Collopy, and excited to be able to share with all the listeners out there a great article that I came across in the Air Medical Journal and some research that he was responsible for. So welcome.
Thanks for having me. I've listened to you guys for a long time, and I think this is the first time I've gotten a chance to join you and talk about some things that are going on in medicine.
Yeah, exciting. Obviously, I think there's been a lot of research in the last few years. The EPIC study highlighted some key areas in TBI management and has changed our focus. But I think what caught my eye with this study was the hypertonic 3%, right? And so if you could just introduce the article. It starts off with a great case study, which I love. And then you dive into the research and we'll just break down your research and break down really what we can take away from what you guys identified, and we'll just go from there.
Sure. So the paper is a case report of the integrated use of hypertonic saline that began in an EMS system. My helicopter transferred that patient and then was dropped off at the trauma center, where we had built a TBI protocol that allowed everyone along that chain to use the same concentration, dosing, timeline for the administration of hypertonic saline, so that it was a seamless continued process. And that's actually really important because a study by Bulger, and I forget all his other co-authors, in 2010 kind of looked like they had put the nail in the coffin on prehospital hypertonic saline. They did a randomized study comparing patients who got a bolus of 7.5% hypertonic saline in the field versus placebo, and then usual care at the trauma center thereafter, and they were tracking outcomes. So they actually stopped their study short because 3/4 of the way through, they found their 60 and 90-day outcomes showed there was no benefit for hypertonic saline. And everyone kind of stopped and said, well, that puts that to bed.
Yeah.
But when you really look at that study and you take a step backwards, they looked at one concentration of hypertonic saline and they looked at a single bolus. It's kind of like saying, well, you gave them a bolus of epi and that didn't work, so we shouldn't use epi drips. Well, no, the single bolus didn't improve outcomes because that's a temporizing measure. And they didn't look at what happened in the hospital. Did they continue hypertonic saline? So we took a step back and said, there's new data that says hypertonic saline is probably helpful. It's probably equal as helpful as osmotic diuretics for increased ICP. Might be a little bit safer. The truth of the matter is no one really knows that yet. We can't say hypertonic saline is definitively better. We can't say this is the concentration to use. We can't say this is the dose to use or when to give it. We kind of have to look at the data because it's really tough to study TBIs.
Right.
But what we have seen is it's probably reasonable to continue it. And so we took the approach, actually, the same EMS system we included in the case study. My crew called me one morning. Hey, Kevin, we got to talk to you about this. We just transferred a patient. We picked up a scene call. They were hanging and they had 3% going. So we continued it on the way. And then it got us thinking, okay, what was the volume you were giving? What was the timeline? When was it supposed to be in? Was this a bolus, an infusion? And they just continued the drip as it was. And I was like, good. That was probably right, given the context.
Yeah.
But we need to look more into this. And what are we going to do? And it really launched a conversation of, well, if you are going to give something as critical as hypertonic saline, you can't do this in a silo. And it really, to me, highlights where we really need to shift in medicine of, I need to stop looking at what I can just do in the back of the truck or the helicopter or wherever I am. And I need to look at what can we do that helps integrate our care into all the other care that this patient's going to have on the rest of their continuum until they're discharged. how can I align it so I am saving that patient steps along the way? And so we built a TBI protocol, and that was where the case report came from, where we worked with our trauma center, our system, and that EMS system, because they had it, to standardize the indications, dosing, and timelines of how fast you're going to give hypertonic saline. So we want everyone to give it over the same 20 minutes. We want everyone to give it for the same reasons. We want everyone to give the same 250 bolus. So field's not giving 250, the hospital wants to give 500, and now I've given my bolus, but it was really only half of the necessary bolus. So let's get everyone on an even playing field, know what everyone's going to do, so we don't repeat a drug. Because could you imagine what would happen if we give a 500 mil bolus in the field, fail to communicate it, because we know a lot of information is lost in handover. That's a very confusing time. And then the hospital gives another bolus, and now we have a bad outcome.
Yeah. And so let's unwrap that piece right there, because I think you said it perfectly. You have to have buy-in from all areas. And I think that's, my travels around the United States, that's what I see as the differentiator is you have some areas where that collaboration is flawless. You take the Pacific Northwest, Portland, King County, right? Seattle, the interdiscipline training with fire and EMS and the hospital systems, right? Your location, Minnesota is like that. There's a lot of areas, and I'm leaving out a lot of great places, but you have to have that buy-in, right?
You do.
That this would not have worked if you implement such a protocol, but the trauma center doesn't buy in, right?
And that's why we wanted to get that paper out. When we first submitted the case study, one of the reviewers gave me Bulger's paper and said, why are you even presenting this? Didn't this paper put the nail in the coffin and say, you don't need to study this anymore? And we replied with, no, it said a isolated bolus with no coordination with the rest of care, separate from everyone else, is useless. And that's really important to say. We've got data that says if you do it by yourself, you're not helping the patients and might actually be hurting them. And so we wanted to put a paper out there so other systems can pull it and look at it and take to their trauma centers, take to their medical director and say, well, if it worked and they were able to coordinate it all here, why can't we do the same thing? It's right for the patients.
Yeah.
And we want to give someone else, hopefully, the tool to be able to open that dialogue and that conversation. And I think what's really important for anyone who's thinking about how to start those conversations, be really open-minded and ask them, what education do you want us to have so that you'd feel comfortable creating this protocol? You can't start it for, well, we can already do this. It's allowed. It's in our scope. That kind of sounds aloof. You got to say, we want to do this together. What are the gaps you want to make sure we close as we build this out through education? And you're empowering them to only give you steps along the way, and you're really preventing them from giving you roadblocks.
Who do you think is the most important person in that wheel of collaboration? Right? Is it you as a program manager or director of research? Is it, right? You're the idea maker, right? Is it the medical director? Is it an administrator? Is it a neurosurgeon in this case, maybe? Like who? I have my opinion because I feel like, well, I'll let you respond and
It's an interesting question. And I started thinking of a couple different answers, but I think the right answer is the person who has the passion to sell the value of the EMS system. I don't care what their title is, because when we sit down at a table, our name tags are underneath it.
Yeah.
When we're at work, our name tags have our first name on it only. So it just says Kevin.
Nice.
It doesn't say Kevin, clinical outcomes compliance. It doesn't say Will, medical director. It just says Will Powers. It just has a name.
Yeah.
We're all on an even player. We're all on the table at an even playing field. And when you're having those conversations, I have found, regardless of the hospital I go to, they don't care what your title and your background is. What they care is, can you carry on the conversation? And are you willing to listen to what someone else's ideas are? Because they're probably pretty smart too and want to be heard. And it's all in who will ask the question and then sit and listen to the answers. So I think you have to have some planning in place. I don't think you can just go by yourself to the trauma center, tell the neurosurgeon you want to talk to them and say, hey, we're going to do this. I think you have to go with a coordinated effort, and you have to say, hey, this looks like it might be really helpful in our system. What would we need to do to get there? Here's the end vision. Let's create a vision. Let's create the end state. For us, it was an integrated TBI protocol. Let's work backwards now. What do we need to do before we roll it out? What do we need to do before that? And you look at every step backwards, because when you do that, the last thing you're going to do is deliver the education. So the first thing you're doing is saying, okay, we're going to need a whole ton of education. And you're putting that on the table of, we're willing to do that work. Now, as you work backwards for the protocol development, operational pieces, where am I going to store the equipment, the drugs, whatever it is, that is all coming after you've acknowledged there's a learning gap we're going to overcome together. And that tells, in my experience, all the key physician groups, you want to learn and you want to understand it, not just have a cool new tool without understanding the risks associated with it.
Yeah, no, I love that. Yeah, you definitely have to have the right person that can pull those triggers, and you have to have open mind, people with open minds, and I think that's so important. And unfortunately, there's areas where that doesn't happen, right? You see it in STEMI guidelines. You see it. I mean, that's just one area. Well, let's talk about really the implementation of the guideline. I'd love to know about, did you do any pre-education? Because I think obviously reading the paper, there were certain criteria that your crews had to trigger off of, right? Glasgow Coma Scale, et cetera, things like that. Was there training prior to implementation, and did you have any roadblocks there?
We did. So everyone got a 1-hour continuing education module on pulling hypertonic saline into TBI care. And we actually rolled the hypertonic saline out before we kind of rolled out the rest of the TBI bundle, and really updated and beefed up that protocol to kind of approach it from the crawl, walk, run mentality. So we didn't give everyone what probably would have needed 5 hours of education when we could break it down into components. So we made it easily digestible. We only made one change in this care plan. Get used to that. Okay, now we're going to make a couple more changes. This is no longer the shock factor it would have had at first. And so everyone took online training. Everyone got some hands-on practice with the drug. And then we rolled it out. And then we immediately put in place a quality management tool to both look at administrations, but also look at all TBI patients to look at missed administration opportunities. And we looked at, did you meet the criteria? And then we also looked at what happened in the hospital in our misses. Did they get it? In our administrations, was it continued? If it wasn't continued, was it appropriate based on the information we had at hand? You walk up, your patient's got a GCS of 7, their blood pressure is 190, they've been hit in the head with a baseball bat, pretty reasonable suspicion that they have increased ICP.
Right.
If it ends up being something else that they were treating, because you happen to have a hypertensive crisis at the same time and they went a different route, there's no way to know that in the field. That would be an appropriate over-treatment. And so I think you have to look at that quality system you set up ahead of time and build that in with the physician so they know what you're looking at, so they can give you feedback and they know who to ask questions to and what the follow-up is going to be.
Well, so in your case study, you have a 25-year-old male, motor vehicle accident. I think it was 12 inches of intrusion. Obviously fluid out of the nose, out of the ears. I think the halo sign was negative, if I remember. Is that right?
Which is a pretty interesting test in and of itself.
Right,
that's a whole separate conversation.
I never do it.
Yeah, I can't say I've... The closest I've come is, remember the old glucose strips that were just color indicators?
Yeah.
We stuck that in the blood in the ear once, and it came back black. I was like, that's not good. That's the closest I ever came to actually trying to do a halo test.
Yeah. The guy declines, right? Pretty significantly. So let's talk about really, and I don't know if there's a difference in the decision making. And we often teach this in any critical care course, is differentiating epidural versus subdural. And I guess it's not really the subdural or recognizing that, because that's difficult without a CT scan. It's recognizing the epidural, right?
Right.
And so we know that they will have that initial LOC. They have a period of awakeness where they're able to communicate, and then you have a slow decline as that blood increases, because we know epidural bleeds are a arterial bleed, right? So we always say it's the middle meningeal artery, or we say the MMA for an MMA fighter. Great way to remember that. They get struck in the side of the head in that terion region of the skull, very weak spot. And so we know that is a classic question on any exam, but you do see a lot of these in the field. Is there a difference? Did you train your crews differently, or was it more focused on, hey, you know what, if the airway declines, if GCS declines, you're going to take care of the airway as you normally will. You're going to manage breathing and circulation, and then you identify those clinical areas that say, hey, we might have a herniation situation. We have a blown pupil. We have a decrease in, I think you guys had a decrease in GCS of 2 points. Is that correct? If I remember
2 or 3,
right?
It was.
Yeah.
And then he started to rapidly decline after that.
Right.
And ironically, he didn't have an epidural.
Right. He had a subdural.
He had a subdural and a really tight head.
Yeah.
Is what he ended up with.
He actually had a subdural, I think you guys wrote. He had a small subarachnoid and a parenchymal. Like he had 3 different, pretty significant.
But they weren't big.
Right.
What's funny is I think that we put a picture up of one of them, had to put an arrow on it because it's really easy to miss, which is a nice message of size doesn't matter inside of the head. You don't have to have a huge bleed to have clinical significance from it. And he was continued on hypertonic saline through, I think, the 36th hour.
Yeah.
They made sure they didn't have any further spikes, and then slowly weaned him down. And so, your question is, did we focus our training on picking up the epidural? And the easy answer is no. We focused our training on recognize the clinical symptoms of any severe TBI first. Okay. Because GCS is what really matters and how they're presenting now. If you can pick up the type of bleed you think it is, that's great. We're already going to a trauma center with neurointervention capabilities. So it's not going to change anything that we're really doing in that process. And I think what I'm finding too in the literature is that lucid interval is often not seen by EMS. So if you catch it and you see it, hey, that's something really good to hang your hat on, of high index of suspicion for an epidural.
Yeah.
And what's hard is we often don't see it, because by the time we get there, if they had a lucid interval, they've already started to decline. But I think there's some good messages there, because an epidural is probably going to decline faster than a lot of your other head bleeds. The other head bleeds, we are going to see them with a more decreased GCS, but they're not going to go further faster. It's the epidural is really your classic, going to deteriorate quickly. And I think that's really important for people to remember and to know and to watch for. And those are probably your most hemodynamically unstable patients of your head bleeds. You brought up subdurals. I've got a slide I love to show when I talk about subdurals that separates out acute, subacute, chronic subdural hematomas. Yeah. We got a laugh out of it this morning when, okay, how many of you have picked up a 65, 70-year-old, you're flying them to the trauma center 3 days, 4 days after an injury, and now they develop symptoms. Everyone's raising their hand. They need a neurosurgeon. How likely are they to deteriorate on you? And I had a couple people go, they're deteriorating. It took 4 days to get to this state. Yeah. The odds of them dropping over the edge in the next 2 hours is probably pretty low. Can it happen? Yeah, but it's not likely to. And so if you're in the EMS world, you're picking up a patient who's now altered, but you can trace back the injury. And for the elderly, it's often a trip and fall at home to more than 24 hours ago. That's really important. You can now be pretty suspicious of a subdural. Yes, it can be something else. But their change, you have to look at that timeline of change. I anticipate in the short term for that rate of change to roughly stay the same for the next little while. Caveat, if they vomited twice on me, right, and they're altered, they're getting intubated. Yeah. Like, I don't care if your GCS is still 12. If you can't protect your airway, you're vomiting twice, I've got to lay you flat or head up, and you're not going to be able to clear it yourself. I'm not willing to add a second risk in and give them aspiration pneumonia on top of a neuro emergency.
Yeah, no, there are so many areas. My mind is just going crazy right now, because you talk about that decline, right? And we don't intubate based on GCS, and we really teach now, hey, can they follow your commands? Can they control your secretions? And what's their clinical course? Those are the three decision makers. I don't care if you have a GCS 15, right? And so really in the critical care world, that is very, very objective,
I
right?
love that you did not say what's their SpO2 in that
Oh,
decision-making process, because people throw a non-rebreather on, it's 100%. That's great.
right.
They have Chin-Stokes respirations. Their SATs are fine, but they clearly have a neurological problem, and their CO2s are going to
Right.
be completely screwed. You can't look at that number.
Yeah.
It's not important in your decision-making process.
Absolutely. I think there are so many elements, when we talk about really the mode of transport, intubating the patient before maybe you get into flight if you're in an aircraft, and decision making and sentinel events and being prepared. And I've seen through chart reviews or in malpractice cases I've seen situations where you have experienced providers that have managed the airway in multiple other scenarios perfectly, but they're caught off guard, right? You're in flight, you opted not to intubate the patient, they all of a sudden vomit, they're on a spine board, and before you can ever react, because I mean it doesn't take but a couple seconds, they've now aspirated. Now you have a hypoxic situation. We don't have the airway kit out and open. We don't have the drugs drawn up. And so we, even as experienced providers, start making very poor decisions. We start rushing it. We panic. And so I think, to go with what you said, we really have to be proactive, not reactive,
Yes.
right? In airway management.
You can't wait for the crisis. Don't wait for now I have a crash airway when you can manage it ahead of time. The trick is you have to be really good at what you're doing and practice it a lot, because hopefully everyone knows pre-hospital intubation of a TBI patient is fraught with complications and is extremely risky for the patient. And even in our best studies comparing apples to apples, we worsen outcomes with uncontrolled intubation. You really have to be good at what you're doing, but you hit it on the head. I think we wait too long.
Yeah.
We wait until they're hypoxic. We wait until they're already fighting. We wait until they have aspirated. We wait till they're hypotensive. And now you have to take a bad situation and give drugs that's just going to make it worse. But you need to give them to facilitate what needs to occur next, which is the intubation. And
yeah, no, you said it perfect. I think where you see this is maybe patient has a GCS of 14 or 15, and you get that crew that says, they're talking to me, they're answering questions, but they don't look at what's going to happen in 20 minutes. And I think that's a controversial topic. You might get 10 flight nurses, flight paramedics that'll say, you know what, I'm going to take that risk, and you're going to get 10 that are going to say, for me, I will tell you personally, I will intubate that patient. If I know I have mechanism, I have a TBI, even if they're talking to me, I would rather be prepared, and we get them to the trauma center and they extubate the patient, because I don't want a sentinel event like that. I don't want a hypoxic event, a hypotensive event. And now we know that third is the hyperventilation, right? So, that bringing that CO2 down like we used to and how we were taught. We know the EPIC study really focused on adding that element to the 3 H's of TBI. And so we want to make sure that we don't add a secondary brain injury, right? Primary brain injury is there. We're responsible for maintaining a patient in a stable environment. Then the problem is when you get on scene and you find these patients that are already hypoxic, right? They're already, you have a brainstem level injury, and they're clenched, trismus, they're breathing 40, 50 times a minute, right? That patient is a difficult patient, right? They're already probably in 2 of the 3 or all 3 of those. And so we have to move them out of there as rapidly as possible, but still be focused on doing the right things. Because I think you said something that is huge, is we wait too long, but we also, I think, based on just historically as providers, we were always taught airway, 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 airway. And what I see is we have still a large amount of peri-intubation or post-intubation cardiac arrest because we're not resuscitating.
You hit the nail on the head. I was going to say, we teach airway, but putting the plastic in the hole is while critically important, is like the least impactful step in the airway management process, and you have to treat the entire patient and look at everything that's going on. You need to fully resuscitate the patient and stabilize them before you move forward. And I think we forget to look at anything more than SpO2. SATs are okay. SATs are important, but they are the last thing to change when a patient is crashing.
Right.
If we went apneic right now, we both would sit here with SATs above 90 for 7 to 10 minutes.
Yep.
And it's going to take us a while before we desat. But our CO2s are going to shoot through the roof. Our acidosis is going to change. And I forget when it came out, but there was actually a great swine study because they wouldn't let us put people in VFib. But they put pigs in VFib and took ABGs at 3 minutes, 5 minutes, 10, and I think even 15 minutes. No CPR, just VFib arrest, and waited for it to pan out. And then they started CPR with compressions only. SpO2 stayed normal for like the first 10 minutes. Your pH started to change, and obviously your CO2 changed because you weren't off-gassing carbon dioxide.
Yeah.
And it was a great lesson of we have time when it comes to hypoxia, but you don't have time to manage these other pieces that you can't see, but are probably more important. And if you only ever train on plastic and you only think about putting plastic in the hole, you're going to forget about all those other pieces of airway management.
Yeah, I mean, I agree. I think, when you look at that TBI patient and this case study, making the decision to go to hypertonic saline, obviously the whole purpose of the podcast. Can you talk a little bit about maybe the difference between mannitol versus going that route? I again have my preference. What do you think?
So it's an interesting conversation, and opinion aside, first let's look at what the literature says. And the best guideline to follow is the Brain Trauma Foundation's guidelines. And all of the ICP management is class 2 recommendations, or level of evidence B, C, and D, barely any B evidence. So for anyone that's not a research nerd, class A, level of evidence A would be like multiple randomized controlled trials, clearly definitive benefits. Level of evidence D is expert opinion. And then again, have gradient levels in between. So what that's really telling us is the evidence is not strong one way or the other. So their guidelines read something to the effect of, we have known for years osmotic diuretics work to lower ICP in the presence or in the context of traumatic brain injury. They then talk about hypertonic saline and say there's insufficient evidence for us to today say we should use hypertonic saline. There's not a clear enough benefit in TBI patients. They go on to say there's evidence that it lowers ICP, probably does it faster, maintains that lowered ICP longer with fewer complications. So you hear that and you go, well, why aren't you recommending it? And it's really because it's the quality of the studies. It's so hard to study that one aspect. Does this one infusion change the course of care and the outcomes? And we truly don't know. But you kind of have to piece together those other pieces. So what do I think about the two of them? I used to give mannitol. I still have like nightmares of how sticky my gloves were every time I tried to give it. I was talking about it earlier today, and someone was like, I've never given it and not had it all over my flight suit. The drug sucks to administer. It's not fun. You have to calculate a weight-based dose.
Yeah.
It works. But if your patient has a polytrauma and they are in hypovolemic shock, compensated or otherwise, you can make your patients really sick really fast with any osmotic diuretic. And mannitol is not benign in that respect. And I pause, especially with the use of mannitol, until we know we are dealing with swelling in the absence of shock and not bleeds. I like hypertonic saline, and why our trauma center likes it is bleed or swelling. It's probably just as safe to give to either of them. You're not going to have the complications. You're not going to have as many complications if your patient does have some hypovolemic shock. You want to rule it out first. You need to resuscitate them first. Please give blood, give blood, give blood, give blood. Maybe give ringers. If you have no other choice, begrudgingly give saline. There's nothing normal about normal saline, guys.
Yeah.
And that's a whole nother conversation. I know you've talked about that before, but hypertonic saline is easier. It's a single bolus. Well, we call it a bolus, but it's really an infusion. You need to give it over 20 minutes. So what we do is we have the bag, and we're going to set it to gravity. We're going to set it not wide open, but you don't want it to be given too fast. If you give it too fast, you can cause some vasospasm. You can cause a really profound drop in blood pressure. And then you'll get a rise in blood pressure as all the fluid shifts because you just really screw up your patient giving it too fast. So you want to give it over 15 to 20 minutes, a real 15 to 20 minutes, not a paramedic 15 to 20 minutes. I like my guys to put it on the pump. Does that probably happen a lot? I'm realistic. Probably not.
Yeah.
I want the drug in.
Yeah. But
you don't want it in too fast. Mannitol, you're going to have to put on a pump. Or you're giving tons of boluses. If it extravasiates, you have a disaster at hand. Hypertonic saline is not much better. Your patient is going to diarrhea, so you need to have a Foley in place, or you're going to get peed all over. And I think the advantages in the simplicity of hypertonic saline far outweigh the risks when it comes to the unknowns. The advantages of mannitol in comparison aren't that great compared to hypertonic saline when I look at the whole picture.
Right.
So we don't carry mannitol anymore. We got rid of it several years ago because no one used it because it was so tough to use.
Yeah.
Not that it didn't work. It was such a disaster to use and to store that it just became not worth it. Hypertonic saline is much easier to store and to carry and to have ready to go. And you can start the infusion and you can move on from a task saturation level, start the infusion, move on, start dealing with something else. Giving mannitol, someone's got to pay attention to that for a while.
Yeah.
Because you have to either draw it up out of multiple vials, and then you're stuck doing that one task. And as a team, there's just two of you in the back of the helicopter or in the back of the ambulance. It's not worth committing one person for that intervention. If I'm going to commit one person to an intervention, I'm going to commit them to something that's much more valuable than mannitol. So, do you like it?
No, I would echo what you said. I definitely, I used it a long time ago when I did specialized rescue stuff. We carried it, and I think, I think it comes back to we've moved away from a lot of the stuff we did in the past. Now, that doesn't mean that the hospital might not go with mannitol, but they're probably better set up. They've got a Foley in place at that point. So no, I echo that, and I think the 3% is probably the best option, right? And you highlighted a study that they did 7.5%, which isn't always a standard. I get questions all the time, and one of the things I want to dispel is, when we raise, obviously we could use hypertonic saline for other reasons. We can raise somebody's sodium, and that gets into the whole hyponatremic, euvolemic, all that stuff that is a podcast actually we're going to do, Ashley and I are going to do. But using 3% for the purpose of TBI is a little different, right? And so you always get the crossover. Well, gosh, if I give a hypertonic saline, am I going to cause osmotic demyelination, right? Pontine myolysis, which, that is something where if you raise somebody's sodium really, really fast, that can happen. But really in the grand scheme of things, that is a rare finding, even in the context of somebody that's hyponatremic. And so, I just want to dispel that that's not a fear. And you're giving 250 mils over 15 to 20 minutes.
Yeah. And so you're really not giving enough to cause that. You start giving multiple boluses, which in the trauma center we might. And that's, if you've got 2-hour transports, you may need to have a protocol that allows you to give some repeat boluses to specific patients. And that's all the more reason to build it with the neurosurgeon to get the timing, the spacing right for what they need, and to look at that whole picture. And if you're giving it nice and slow, you're really going to avoid some of those. Ironically, we did a study on completely separate, but kind of linked dosing related learning lesson. We randomized ketamine and etomidate a couple of years ago in pre-hospital RSI and looked at the differences. We actually ran a dual arm study and compared it to the ER. And so we saw in the pre-hospital arm a late onset of hypotension in our ketamine patients that we did not see in the emergency department. And so we started looking at why. And we realized pretty quickly as we started talking to our providers and then our pharmacists, it was purely administration rate related. We're getting ready to RSI in the field. It's just the two of us. How quickly is that ketamine going in?
Yeah.
It's in. It's already in by the time I'm done asking the question. Well, in the ER, they actually give it like it's supposed to be given over about 2 minutes to pushing 3 minutes. And you get the same effect afterwards, but because they're giving it more slowly, you don't get the delayed hypotension that we were seeing in the field from some of the side effects of the drug. And so we're still finalizing the paper and going to get the whole paper out there as we put all the data together. But it was a really interesting finding because it really cemented, folks, like how you give a drug is actually really important.
Yeah.
And we have data to show that now, that you give a drug too fast, you give it wrong, you can actually see complications from that you're going to have to manage. And you might not realize that it's from the drug. You're going to think it's a deterioration in the patient. And sadly, we did it. We caused it. We don't necessarily see it as a complication because we're not thinking about how that drug is impacting that patient. And, we need to do a better job understanding the pharmacology of the drugs that we're giving.
Oh yeah, no, I agree. You hear that a lot. You hear, well, it's because it's a potentiation, right? And ketamine is bound completely different than, fentanyl or Versed, where they're very high protein bound, and Versed or ketamine is not. And so I love that you said that, because I think that's also a hot topic. I mean, we could go so many ways with this podcast, and I think the other thing I took away from this paper was you guys talked about treating the pain. And I think we really forget that a TBI patient, and I also want to talk about really understanding herniation, recognizing herniation. What does that mean? Because that can mean a lot of different things to different people. But we have to remember that pain by itself will raise anybody's ICP.
Pain, anxiety,
absolutely,
stress,
inhibition,
noise, seizures.
Yeah.
So there's a whole piece of a TBI care bundle. I call it eliminating the central nervous system stressors. So anything that's going to stress the central nervous system will raise your ICP. Analgesia is the easy and the big one. You've got to treat pain. Even if they're not talking to you, if they have other injuries, their body is sensing pain. If you have increased ICP, that hurts.
Yeah.
You need to give them analgesics. Preventing seizures is a whole nother conversation we could get into on Keppra. And that's super important. We don't want to wait for them to have seizures. We want to prevent them from ever occurring. Noise. If you're in the back of a helicopter, even if they're comatose, get hearing protection on them, because that's a stimulus. That's going to stimulate them. That's going to make them, make their central nervous system stress. And even some of the interventions we do, like pay attention to your seatbelts, fractures. For the love of God, my pet peeve is people who tell me that they stabilized the long bone fractures by putting them on a backboard. A backboard does not splint an unstable tib-fib fracture or an unstable humerus fracture. Get a splint on them. Is it what you need to manage before the airway? No, but American Association of Orthopedic Surgeons has a great position paper on that says, don't delay fracture management. It is actually a critical component of managing the whole patient, and it deserves to be managed in the field to limit long-term damage and to reduce pain. So get a splint on them, please. Like it's a huge step in managing your patient's pain, is simple splints. And frankly, we suck at them.
Oh, I would agree. And I'll be the first to say, reflecting on me and my career, that was absolutely the last thing that I was worried about, was unless it was something where it was compromising circulation.
Yep.
I was not worried about that.
Because there's other things for us to take care of, where you put a pillow on. My uncle was an orthopedic surgeon, and he's the one that hammered it into me. So he'd start quizzing me, and I'd stumble through orthopedic injuries. Now he took them deeper than you would imagine.
Right.
But he'd ask me, then he'd turn to the heart and ask me about heart things. We'd talk about that for half an hour, and he'd stop and go, "Why can you tell me so much information about the goddamn heart?" His language, not mine. He said, "But you can't tell me about ankle reduction." Uncle Mike, which one's going to kill you? Oh, fair. He said, "Well, which one is going to cause your patients more pain every single day of your career?"
That's true. That's
touche. He's like, bang for the buck, man.
Different
You
perspective.
should know how to treat this. It's not fair. It's like, you're making my job harder by not treating these things.
Yeah.
And so you have to treat pain in your TBI patient. So sedation is a kind of a touchy subject, and especially in your mild TBI patients that are fighting you a little bit, especially if you're not going to intubate, because if you're going to use ketamine, ketamine is a great drug that's going to give you both a little bit of sedation, a lot of analgesia, can give them a dissociative state where if they're in pain, they're at least not remembering it and they're calm. Your benzos, which is probably what most people are carrying, and they're thinking, well, give them a little benzos. Like, be prepared, especially if you're giving these other drugs, for a little bit to go a long way and for it to really wreak havoc on your hemodynamics. And you're not going to see it giving 2 or 4 of Versed in the first 2 or 4 minutes. You're going to give 2 and you're going to go, well, they're still fighting me. Let me give a little more. And then let me give you a little more. And then all of a sudden your blood pressure is going to be 60. And so while they will sedate your patient, they will give you hypotension. They will give you hypercarbia, because they're going to give you respiratory rate depression and volume depression. And you're not going to see that until you're really behind the 8 ball. So guys, you got to sedate, but really be careful with your benzos.
Yeah. And that comes back to understanding pharmacology and how medications, we learn it in paramedic school, potentiation, right? But we don't go into plasma protein binding and all that goes into how 2 medications that are 99% protein bound, how they coexist. And,
Right.
Fentanyl and Versed are those 2, which we've used for the most part in my career. Those were the 2, and then you go way back, we used morphine, right? And we know that's
Right.
changed. But so what were the key areas? Herniation is obviously something that I think we teach a lot. I see that answer missed a lot. And I think the differentiator is understanding that a patient with ICP will have tachycardia, the Cheyne-Stokes respirations, erratic respirations. They have that hypertension or widening pulse pressure. The differentiator is the heart rate, right? When that heart rate changes and it goes from tachy to brady, that really is where you can start seeing, and what we say is Cushing's triad. Hopefully we don't see that in the field. I've had one patient my entire career where I saw herniation, Cushing's triad, in my presence. And it was just a catastrophic head injury.
I've had one as well that,
yeah,
like, what happened.
Absolutely.
And I think my take home message on that, it was really sad because it was a 7-year-old. We were driving her for pediatric neurosurgery because we couldn't fly. Of course, the days those kinds of things happen,
Yeah.
you can't. And we were fighting. She was fighting. She's tachycardic. We're dealing with her blood pressure. We had her intubated, so I couldn't see respiratory rate changes. We had her paralyzed. Her heart rate shot up from she'd been in the 120s to 150. Her blood pressure went from we're trying to keep her in the low 100s to her blood pressure spiked. Heart rate dropped into the 50s for about 15 seconds, and then everything normalized. And guys, that was it. We looked at each other and we're like,
yeah,
we're done.
Yeah.
And we looked at her eyes, her pupils were dilated, fixed and dilated, didn't react to light. And we were able to take off all the vasoactive drugs. We stopped them, and her body just didn't know it yet.
Wow.
Unfortunately, she went on to organ donation, so they were at least able to harvest, and pass on life a little. But yeah, when you talk about herniation is fast. Herniation can occur more slowly, but in acute trauma, it typically occurs pretty quickly. And I think we think of Cushing's as this period of time that lasts multiple minutes, 10, 15, 20 minutes. It can be as little as 90 seconds where you're truly in profound Cushing's, and you want to avoid that point. And herniation is not, I know you know this, but people do, we're not actually herniating the brain outside of the skull. Herniation is the brain pushing through the tentorium, that is connective tissue in the skull, and you're basically pushing from the top half of your skull to the bottom half of your skull, and you've squeezed the brain through, but it all stays inside your skull. Your
Right.
brainstem and your spinal cord are what's coming out of your skull, and it takes up the entire space. And between that and connective tissue, there's no brain matter coming out there. If you have a hole in the head, you could herniate through that. That's a different conversation. You're going to see that one. That's going to be kind of obvious.
Yeah. No, and so taking that a step, you often hear with normal saline, you hear, well, I'll just throw a question out there. Hey, could we use 23% normal saline, right? And so I just want to discuss that really quick. That is obviously used, and in my experience, that's used in what they call a neurocode, right? They have true herniation. It is the last little life-saving maneuver to try to turn somebody around. in my experience and working with, nurses that work neuro ICU like John Hopkins and stuff like that, usually it's a last ditch effort that is really moot, right? It's not going to bring them back. And so that is obviously, and that's a bolus dose, kind of similar to giving our epi. So, I think this podcast is it highlights a lot of great stuff, right? We could go so many different directions. We can talk about, is it the recognition? Is it the resuscitation? Is it not allowing secondary brain injuries, the hypotension, the hypoxia, or not moving them out of that if that's how you find them? Not focusing on the hyperventilation. I'm still seeing people not even know that that's a new standard, right? That we don't want to drive end-tidal CO2s down. And not having those sentinel events. You said something powerful. You said continue the care from pre-hospital all the way through the care cycle. And I think we're very poor at that, right? I think that there's areas of the U.S. that are really moving that direction, right? We think about SALAD. SALAD is all about VAP, ventilator-associated pneumonia, and we never were taught that.
And it is in intubation and airway management, VAP prevention is so critical. That's a great example of how we can extend it out. And part of what we need to do is move beyond. I think there's a place for statewide protocols. I think they're important. But statewide protocols aren't bringing all the players in to say, how does this set you up for all diseases to what's going to happen in the hospital? Some it does. The bundle of care for STEMI everywhere is going to be nitro, aspirin, some sort of analgesic. We used to think you have to give morphine, but that's gone too. And maybe in some systems, heparin, because that's going to help you along the way. And so that's pretty easy to standardize. Sepsis care is probably pretty easy to standardize, but you can't use one antibiotic across the entire state and say, give everyone Rocephin, because not everyone needs Rocephin, but I'm seeing places now that are doing that. You want to give the same drugs and be able to adjust them. So you might have a protocol across the state that says, give the fluids, techolactate, give an antibiotic per local guidance. You want that same antibiotic they're going to give in your ER to help provide antibiotic resistant stewardship. And so we need to start bringing in having those conversations together, because that is what adds value to our critical care transport and our EMS systems as a part of the healthcare community. If we're going to do it our own way, we're not going to engage and look at outcomes and look at integrating it together. That's what's going to keep us stuck as being transport. And we want to be seen as a health provider where we're simply just providing medicine while mobile.
Yeah. And, it goes back. We'll kind of wrap this up. I think this has been really packed with a lot of great stuff. I go back to something we discussed earlier. And I asked you, who is the most important person in that decision-making tree to implement a program like this? Or let's even make it more broad, to have a guideline that is more focused on current evidence. And I truly feel it's the medical director, right? You as a researcher or as a training officer or clinical manager, you could be up on all the top evidence base, right? Mm-hmm. You could be citing meta-analysis, not observational, not expert opinion, but true, strong meta-analysis or RCTs that have a lot of strength to them. But if you don't have a medical director that is passionate about EMS and wanting to progress the practice, you will not get anywhere. And that's what I see. I see that. I see people email me all the time, and they have a lot of great ideas, and they have a lot of employees, paramedics, nurses that want to do these things. They don't have the backing of administration or the medical director. And so why do I say medical director? Because the buck stops with them, right? In most cases, what the medical director wants, medical director gets, right? Mm-hmm. Now, obviously, if it's a budgetary thing and they're wanting to spend a couple $100,000 on, 5 or 6 Hamiltons, that's different. But when you're implementing guidelines, that usually is a medical director decision. And so I can't stress it, for you guys listening. If you have ideas. I know Kevin is a great person that you can reach out to, and we will leave his contact information. It comes down to starting those conversations. That was one reason why we started this podcast, was to open up the dialogue and share research and get the information out. And a lot of times they might not even know that there's current research out there on a subject, right? It all depends on how engaged they are in the industry.
None of us, I don't care who you are, have read every study, read every journal that comes out. And we have to be humble. And Eric's going to have research that he's read that I haven't seen, and vice versa. And that's when you bring brains together and you say, well, what have you seen? Here's what I've seen. Let's pull all the paper together and let's see what we really understand. And we're going to be better together for doing that. And so, medical director is a great person. You need to have them engaged. You're absolutely right. You don't want a medical director that's just going to rubber stamp everything. And you don't want a medical director that's going to say no. But have the data and the research to go to it. And if you don't know how to pull the research, ask them. If they don't know how to pull the research, phone a friend, and hopefully you can help educate each other on how to find that research better. And we're always going to find other data and information that's out there. Every day, new research is published. What we all learned in paramedic school 5, 10, 15, 20, 25 years ago, depending on when people went, a lot of that's old, outdated medicine. And if you're still resting on the heels of what you learned, the textbook was 5 years old if it was a new textbook.
Right.
We write textbooks. I loved it because Tyler just finished writing a paper, a chapter for one of the paramedic textbooks that came out. And you ask him about it. He finished it probably 18 months ago. It just finally came out. So if he was basing it on data 18 months ago, what's changed?
Yeah.
And
you're absolutely right.
It takes a while. And that's not to say textbooks are bad. And that's a whole nother conversation. I just want to make sure I'm clear. Textbooks are great. We have to have a foundation. They are great for baseline field entry. They're not the source of continuing education. They are the foundation. They are not the entire structure of our learning.
Yeah, no. And we're all currently authoring, a lot of us, the Principles of Practice 6th edition, and so it's, the big thing is don't cite any evidence in there that's greater than 5 years old.
Yep.
And I think I'm very careful to put things in there that I feel like are going to change or might be on shaky ground. So no, I think that's perfect. Well, guys, again, if you ever have any questions, you have case studies, you have questions for Kevin, please, reach out. You want to share your email?
My email is kevin.collopy@novanthealth.org, NOVANTHELTH. And otherwise, you can find me on Twitter. Is probably the easiest way to get a hold of me, is @KTCollopy.
Awesome. Yeah. And as always, right, reach out if you have case studies, if you have ideas, if you need help with anything that we talked about today. Please do so. Again, thank you for coming on the podcast.
Appreciate you giving me the opportunity.
Yeah,
it's been fun.
Yeah. Check out the article, Elsevier in the Aeromedical Journal. I believe it's the last case study of that journal. So the one that just came out. Appreciate you.
Yeah, thank you.
All right, guys. So I will talk to you soon.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.